I just wanted to go over a couple housekeeping things before we get started, and then I'll send it over to our moderator, Emma Schrar. So please first make sure your microphones are muted. And then we will be taking questions throughout this presentation. So please send your questions in the chat function. Also, this meeting is being recorded, and we will post it on our website where you can access it later. Quick background on Corner House. We pursue safety, justice, and healing for youth and their families who have experienced or witnessed abuse. We realize this purpose through work in prevention, intervention, and ending abuse in families. And we strive to assist families in stabilization and healing. Additionally, today in the audience, we have the Otto Bremer Trust Center for Safe and Healthy Children. I would like to give a quick shout out to them and let you know about their upcoming Child Abuse Summit on August 24th through August 26th. The event is being held entirely virtually and is designed to provide professionals from all disciplines with the knowledge and tools and skills to identify and treat all types of child maltreatment, including physical abuse, sexual abuse, and neglect. Registration is $75 for all 3 days, and I will put the link to register in the chat box of this meeting. Lastly, for the speaker series, we would love to include a broad range of voices involved in child advocacy. If you have a topic in mind or would like to be included in a future installment of this series, please send me an email at ivy@cornerhousemn.org. So, to get started, our panelists would love to know a little bit about you all and where you're coming from, what field you work in. So I'm going to start a poll. And if you would mind just answering this question, what is your field of work and what brings you here today? Just so our panelists can better gauge their conversation. So I'll give you a few seconds to answer this question. Awesome. So looks like we have a good amount of people in the Children's Advocacy Center field, a lot of people in child protection, some folks in other social services, and a few amount of folks in law enforcement. So thank you so much for taking that poll. That sure helps us a lot. So I'm going to end that poll here. Awesome. So I'm going to send it over to our panelist, or our moderator, Emma Schrar.
Thanks, Ivy. So as Ivy said, I'm Emma. I'm also a case manager at Corner House, but I will be moderating today. So I'll be asking the panelists questions throughout this whole presentation. And then we also encourage you, as Ivy said, to ask questions in the chat. I'll be fielding those throughout. And then we'll also leave a little time at the end for you all to ask more questions as they come out too. So with that, let's get started. I'd like to introduce or have our panelists introduce themselves. So Sarah, why don't we start with you?
Sure. Hi, thanks for being here, everybody. My name is Sarah Lockhart, and I am the Family Services Director here at Corner House and a therapist.
All right, Tina.
Hi, I'm Tina Strong. I'm a family services therapist at Corner House.
And Rachel.
Hi, I'm Rachel Alexander. I have been a family services case manager for about a year now.
All right, thanks. And then I believe Sarah has a just a little informed consent to.
Yeah, Absolutely. So I think we just wanted to name a couple of things about this presentation. So obviously this is going to be a conversation, a back and forth conversation that we're having, and we invite you to ask questions. As we are speaking about domestic violence, interpersonal violence survivors, victims, witnesses, we may be using different forms of language, and it could be gendered language based upon the population that we serve. But I want to acknowledge that we know that interpersonal violence happens between all people, from all cultures, socioeconomic status, background, race, across rates, similar rates across the population. And we also know that violence happens between people of all gendered, non-gendered, non-binary identities. But we do see a majority in terms of the population that we serve, victim witnesses who are women who have been abused by men. We know that 1 in 4 women will experience domestic violence in their lifetime. And so we see that population more specifically within our work at Corner House. Not in entirety, but we do see that population more than others. So that language might be used in case examples, but know that we recognize that. Yeah, that's what I wanted to share.
Thanks, Sarah. All right. So let's start with our first question. Since we're talking about domestic violence, what is domestic violence?
Yeah, just so we're all kind of on the same page as far as what we're referring to when we talk about this, we define or think about domestic violence as a pattern of hurtful behaviors that one person uses to gain and maintain control and power over another person in a relationship. And so, I mean, we all, or not we all, but many of us know that there's different types of abuse. That, you know, there's physical abuse where you hurt someone's body, or destruction, or abuse to a beloved pet. There's emotional abuse, hurting someone's feelings or spirits, like insults, put downs. Psychological abuse, so that's you know, intimidation, threats, some of those unspoken consequences for various actions that you just know are there. And then sexual abuse, so forcing sexual contact on another person. And we're thinking about all these things in the context of there being a power differential. So we have a, yes, there we go. We have a slide there, and there's lots of different models for looking at, you know, the abuse cycle. And one of the reasons why I like this, the escalation cycle, is because we look at how there might be the calm kind of recovery period, or you know, everything's hunky-dory, things are going okay. There might be some type of environmental factor or life event that causes some stress, the agitation builds, things start to escalate until it reaches this peak of where there might be a violent or abusive incident. And then typically there'll be a de-escalation back down to the recovery period of asking for forgiveness, being nice, trying to make up for the violent or abusive event. Now, one of the things that I like about the escalation cycle is that over time, not that I like the escalation cycle, but this particular model is that over time, what tends to happen is that the peaks or the escalation into violence or abusive events become closer together and more frequent. And then the recovery periods actually become shallower and shallower. So you kind of see this going like this, but then it kind of just starts to be up here, where it could even be where there isn't really anymore a recovery period or kind of a makeup period or that healing time. I think that's all I wanted to say about that. Just be brief, because I know a lot of us are coming with that knowledge already. So
Yeah, absolutely. So how do you all see this showing up with your clients within your role at Corner House, and how are they presenting?
I think this is for both for non-offending caregivers that we see bringing children who have experienced abuse at corner house or witnessed domestic violence, as well as for children. I think what we see is that domestic violence for both children and caregivers who have been victims or survivors of domestic violence is that it affects the whole person. So psychologically, emotionally, cognitively, spiritually, socially, it impacts the entire person, entire child. And so we see a variety of effects in each of those areas throughout treatment or throughout the service that we're providing.
Yeah, and so I am a case manager here at Corner House. And so when the family comes in and the child is being interviewed by one of our forensic interviewers, I'm actually speaking with the caregiver during that time to offer support and resources. And so it shows up in many different ways when I'm working with them and trying to support them. A lot of the times the caregivers are talking about that control piece. I think Tina had said that about them controlling a lot of the areas, if not all of the areas of this caregiver's life. So it's who they can speak to, what they can do and when. A lot of the times that pops up, blaming the caregiver. Why did this happen underneath your supervision? This is all your fault. That this has happened to our child or to the child, deflecting or minimizing. A lot of joking around, that was just a joke, or I didn't mean that, or really minimizing the behavior of what they're doing. Withholding financial or withholding money, so not allowing them to work or working part-time or not allowing them to have access to the money. Using the systems to control their behavior. This is what the system is doing to us, again, and placing that blame on the systems. Disrupting services, so not allowing the child or the caregiver to receive therapy or go to doctor's appointments or even work with Corner House. And a lot of that is stemming around the manipulation piece. And as Sarah said, it's a combination of a lot. It's that emotional, psychological, gaslighting, those sort of things. And how that's presenting in when I'm working with caregivers, a lot of the time that's fear. So they are in fear of, if they're working with me at Corner House, that child will be in trouble at home or might get hurt, or they might get hurt. Or if I say something to someone, my child might get hurt or will get in trouble. So they might put up walls. They might not want to receive services, even though deep down they really do want services. They will kind of shut down. They sometimes will be calling me every day or having poor boundaries, having sometimes showing up randomly at Corner House or places because they might feel safe. We might be the only person that was hearing them or listening to them. They might feel paranoid of certain sort of things. There really could be presenting as disorganized or not being clear, non-linear about their stories of what might have happened. They might be angry, sad, crying. So many different ways it might present itself when working with clients, specifically for me during the interview accompaniment, and then also working continuously with
them.
Yeah, go ahead, Tina.
Sorry, okay. So I know Sarah and I, so Rachel works in case management and will be with people during forensic interviews as far as like being with caregivers. So she'll see a lot of that as they come into Corner House for the first time. And as she said, continues to work with them. We see a lot of similar presentation with the caregivers that we work with once they enter into services and in our therapy services. So like Sarah and I are both therapists there. Part of our intake process, we'll see, we'll see some of these presentations and effects. But as far as working with children, we see the effects with children too. And a lot of times we'll see the inattention, the hypervigilance that comes across as maybe ADHD. And so a lot of kids get misdiagnosed as ADHD when really it's hypervigilance, anxiety, and trying to pay attention to everything to assess for threat. They sometimes will have quick attachment because they come in and they find themselves in a safe place with a person who's unconditional and safe. And so we'll see a lot of maybe quick attachment or poor boundaries. So maybe wanting to be physically close to therapists, whereas, you know, it might not be appropriate for someone you just met. Or sometimes we see the opposite, like separation anxiety, like highly anxious to go into the play therapy room with a therapist without the caregiver. And that transition process might take a long time for them to get comfortable and trust the space and ourselves to be with them. I don't know, Sarah, if you wanted to jump in with anything, but there's a lot that we see,
Yes.
a lot of the effects. So
Yes.
I don't want to do all the list here.
Yeah, absolutely. I think, you know, we see a full spectrum, and that's why it can be really difficult sometimes to assess, because the differences in how the effects of domestic violence have shown up for children is so dependent on their development, their, you know, resilience and coping skills that they've already developed, their protective factors, as well as if they really present with more internalizing behaviors or externalizing behaviors in how they're responding to their experiences of trauma. And that can show up in a lot of different ways when it comes to those emotional, physical, psychological responses. We see a lot of shame and guilt, a lot of children believing that it's their fault because kids are egocentric, and they should be. It's natural for them to be. They believe that what's happened to them and in their family is a result of something they could have controlled. And helplessness and powerlessness results then. So that helplessness and powerlessness can look a lot like shutting down. It can look a lot like not disclosing what's happened. It can look a lot like really hesitant to open up or trust other adults. Anger can be another huge one that we see, not knowing how to manage those difficult emotions, partially because of how, you know, relationships have been modeled. If they've been witnessing chronic domestic violence, we know that domestic violence is less likely a one-time incident, but a long-term chronic circumstance that can be passed on from generation to generation. And we see a lot of somatic symptoms. So children who are also maybe not having words for their experiences, depending upon their developmental age, and who are showing us how they are feeling through stomach aches and headaches and being sick often. And that can be hard to detect. And we have to use our multidisciplinary team and be in communication with other medical professionals too, in order to determine what's going on sometimes for children. But bedwetting, nightmares, other forms of regression is also really common and natural response. Children are going back to a safer place in their body in order to, or maybe to a place when abuse wasn't happening in the home, in order to manage and cope. It's a body reaction.
I'd also like to add that, you know, sometimes we start services with kids at, you know, between age 4 and 5 up through 12. But if there was violence happening in the home when they were an infant, we can see that kind of play out in their play and in their interaction style. So like Sarah said, a lot of those somatic things, a lot of the regression going back, if abuse was happening pre-verbally, we'll see that manifest in different ways, you know, with regression and messy play and things like that. You know, yeah, and sometimes that helplessness and powerlessness that Sarah mentioned might come across as the aligning with the person who used abuse, because that is safer. It's safer to align with the aggressor because it protects you from being a target of aggression. So just wanted to add that in.
Yeah, that's really common, in having mixed up emotions towards that, the person who's used abusive behavior, really loving them and feeling angry with them and missing them if they've been separated from them. That's really common as well.
Thank you. So you guys have explained some of the effects that DV or the domestic violence shows up with clients. So what is that like? What challenges do you experience when you're supporting them and navigating with these clients?
I think Rachel mentioned, already that sometimes, we'll have clients show up without an appointment, needing our immediate attention. Like they might show up in crisis mode. Phone conversations sometimes might take a lot longer than what we had anticipated. Because of the amount that they're holding emotionally and in their heads that they're trying to get out, and just trying to keep track of and support them through.
Yeah, I think we see a lot of sporadic communication as well from caregivers who have experienced abuse or might actively be experiencing abuse. And I think that's really associated with that cycle of violence that Tina talked about. So depending upon where that cycle of violence is, if they are still in the relationship or that has become kind of a natural interpersonal pattern, the form of communication that caregiver may be using might correlate with the cycle of violence. So may increase during phases of escalation or crisis, may decrease during the honeymoon phase, or you might feel like your client kind of dropped off the face of the earth for a period of time. And children can also mimic the cycle of violence as well in terms of their play, in terms of their engagement in services, if that ongoing abuse is still happening.
Mm-hmm.
Yeah, and some things that I experienced too when working with clients of domestic violence is a lot of times they're not following through with appointments or phone calls, or returning my phone calls, treatment goals, or restraining orders. And it's not because they're not wanting to speak with me or get help or assistance or support. It's a lot of the times that they aren't allowed to call people back, or they're not allowed to answer that unknown phone call, or it's not safe at that time for their kids. Maybe it's not safe for them to be able to say, like, I'm working with someone through this, or that they had a bad experience with their abuser last time. Like last time I went to the doctor, that person might have thought I was cheating or blaming me or doing these sort of things. So it's a lot of patience working with them and working through, them not following through. And that is coming back to what is safest for them and their kids at that time.
Thank you. So how do those presentations get perceived as you work with these clients? When your feelings that come up, anything like that?
Yeah, I think that when I'm working with caregivers, a lot of times different systems are involved. And so there's many different players in the ballgame. And so when they are actively going through domestic violence or have experienced this in the past, they might still have some of those symptoms of being paranoid or, poor boundaries and those sort of things that we talked about previously. And so that might come through as being difficult, or that they're not compliant, or that they're not a good parent to their child, or that they have mental health concerns. That comes up a lot, that they are unstable, that they're not best fit for that child to be their parent. And a lot of the times they say, like, people ask, why am I choosing to stay, even though that might be safest at that time. And a lot of times the things that we're perceiving are protective factors versus things that are opposing to that. And so when working with them, a lot of things can be perceived in a different way. And in fact, they're doing this to keep themselves or their child safe.
Tina or Sarah?
Yeah, I mean, we see that as well when we're when a family is starting therapy services with us. Also, like with caregivers, we'll see in addition, during our intake process, when we're asking for their story and for what their experiences. Sometimes they'll be telling us these reports of abuse with like very flat affect or no emotion, and you kind of just think, well, if someone's talking about abuse or the specific abusive incident, like they should be crying, they should be angry, they should be emoting, but they may be talking about it with little to no emotion showing, or flat affect, and that's very protective. It can be perceived as not caring or fabricating or not being protective, not wanting, whatever, like this didn't matter. But really it's that numbing that's allowing them to talk about it and get through it without re-experiencing, and to just be able to function through the report. With kids, and also we'll get missing information. So if we're trying to establish timelines of things, there might need to be a lot of kind of like going back and checking and asking really more specific questions, just for holes in the memory or things like that. A lot of non-linear accounts and reports. The narrative for someone who has experienced chronic abuse is not going to be a linear, coherent narrative. That's not possible for them or for many people. So, and we've talked, and then Sarah and I have talked about some of the ways that we see it, how there could be misperceptions about a child's behavior, as far as like, with the inattention or the fidgetiness or the constantly having to be moving or regression, distracted, avoidant, things like that, wanting to be with the person who perpetrated abuse, asking about them, showing the mixed emotions like Sarah mentioned, difficulty with transitions. But then there's things that we see specifically too in domestic violence and child abuse cases. And Sarah, I don't know if you wanted to speak to that a little bit more.
Sure. I mean, I think something that we see quite often is if a child honestly, that the child is doing just fine. So sometimes I think these are the kids that slip through the cracks the most, are children who are maybe functioning well in school, might have more of those internalized behaviors that are harder to detect when a child is first coming in for services, or brought in for a forensic interview. They're doing well in school. They're not reporting any of the abuse because it is not safe to do so. And they've learned that to protect themselves that way. And so the child's perceived like nothing is wrong, and maybe referrals to other services, would not happen if they weren't coming to us. Or the child might be perceived as the opposite of that might be the child is perceived as lying or aligning with the protective caregiver, whose parenting isn't being perceived as safe or protective, though they're making choices that are confusing to providers, but they're making choices that are safest for them given the circumstances of interpersonal violence that they're experiencing. We might also see the parents who are trying to encourage their child to engage in safety planning with them, or using assertive communication, or encouraging children to talk to other safe adults within different settings about what they're experiencing if they have not been believed the first time that they have reported abuse within a setting. And that's perceived in many different ways, I think, by different providers, and can be really confusing to navigate when you're hearing different stories from different family members.
I know we chose this tornado image, so I was wondering if one of you could kind of speak to that as well.
Yeah, I'll
Well,
speak to it.
Oh, go ahead.
Sorry, I can't see you, Tina. I can only see myself. So I really like this image is because this is what the caregiver might be experiencing, the child might be experiencing, and then also what a provider might be experiencing with them as well, of just how chaotic and how linear, and we're trying to put together the pieces, and so is the caregiver, of how to best support the caregiver or the child. And then also the caregiver is saying the same thing, like, how do I best support my child through this, and trying to put together the pieces during a tornado and afterwards. And if there's continuous tornadoes in their home and any environment that they might have, putting that back together or trying to piece that together is hard. And then also having that in your brain, I think with the left image continuously might put you in a whirlwind of things, especially when there's multiple providers or systems involved, and how do we keep everything straight. And sometimes providers might seem or say like that misconception too of like they might not have it all together, or why aren't they doing this, and just kind of like what they might be experiencing. So I think this is a good representation of how they're internalizing it, and then how they might be presenting during like meetings and calls and things.
I think something else to note is that image might be also internally experienced by the providers who are providing a service to victims or survivors of domestic violence. That oftentimes the empathy and the time that you are taking as a provider to work with an individual who's experiencing ongoing abuse, you are taking on some of those and holding some of those emotions with them as you're working with them, and the chaos and the presentation or the way in which they're showing up in relationship with you can be that kind of parallel experience that you begin to experience as you're working with them. And so I just encourage people to give themselves grace, as well as building that self-awareness and using that self-awareness and gut instinct that you have as a provider, regardless of your role, to notice when that's coming up for you, because that's another red flag that something else might be going on if the caregiver or adult in the relationship has not identified that they've experienced abuse, and maybe a safety assessment hasn't happened yet.
Thanks. So what are your thoughts when you're working with those caregivers then, as you are seeing these challenges come up, or some of the things that make it harder to work with?
Well, I think what Sarah said is use that kind of that parallel process, or that feeling that's being elicited in myself when I'm working with someone, to be a clue, to pay attention to what's going on, and kind of do further assessment if there's safety planning that's needed, or if there's something else going on. So using that internal process as a clue. I mean, trying to observe and say, what is this behavior accomplishing for this person? What is the threat? Like, this person is acting as though they are being threatened or feeling a threat. What is the threat that this person is feeling that they're trying to protect themselves from? And starting there, kind of trying not to follow the feelings of, oh, this is so chaotic, and it's really hard to, contain this person, and it's bringing up a lot of anxiety for me. Like, stepping, what is this behavior serving for this person? We might, the shutting down. What does the shutting down serve? Well, it protects them. I might mention this later, but a closed system can't take in any more information. And if you already have too much information or stimuli coming in, that shutting down and that numbing protects you from being overwhelmed. You also shutting down, or maybe disengaging a bit from systems, it could be threatening to ask for help, or to invite someone into your life who might try to help and support you. It might get you in trouble with the abuser, especially if there's a lot of isolation and going on. The shutting down is protective for both the child and the caregiver when we see that. So trying to look at some of those behaviors as how is that protecting that person? What threat are they feeling that they're acting this way? And seeing their behavior as a way to protect themselves. You know, we talk about defenses, and I like to use protective factors too, but how are they protecting themselves right now? And just being curious about that, instead of assuming like, oh, they don't want services, or they're being difficult, or they're just so disorganized that, you know, I'm having to manage this a lot with them.
Yeah, so you mentioned,
go ahead.
sorry. No, so you mentioned protective factors, and I think a few of you have said it. So really, what is a protective factor?
Yeah, there's a lot of different definitions of protective factors, and keeping in mind that protective factors can be external to the child or family that we're working with. It could be supports in their community, extended family support, safe people to stay with, healthy role models in a child's life, regulated caregivers so that the child learns regulation. But in this case, I think a lot of what we've been talking about is protective factor can be kind of an attribute or a behavior or a psychological mindset even of a caregiver who is engaging in those behaviors or making choices to keep themselves and their children safe as best they can when they're experiencing domestic violence. Oftentimes, I think this is subconsciously. It's, you know, if you're experiencing active domestic violence, you are living in that fight, flight, freeze response. And so sometimes these protective factors are just natural instinct. You know, if a tiger is coming towards you, you know, how do you act? You might freeze, you might run away. And those are some of the behaviors that we might see that present themselves, like the tornado that we talked about before, as a result of the experiences of abuse. Yeah.
So then why are they so important to know?
Well, I think they're important to know because it's easy to interpret them different ways. So it's easy to interpret them as being maybe harmful or inappropriate with the child, maybe non-caring or unsafe, when reality, just like Sarah said, that they could be learned in their body or in their mind, consciously or unconsciously, to be able to protect their child and to be able to keep them safe. So maybe getting, for example, is that they have received help or been able to protect their child when they've gotten louder with their voice or their bodies in a system so that they can actually be heard or seen to be able to protect their child. So it's definitely a thing that they might be experiencing. So a protective factor, just like here, it could be obtaining OFP or a restraining order. It could be staying with the abuser. It could be that the abuser has all the financial money or are threatening the children if they leave, and so the caregiver decides to stay because that's the safest, is when they don't get abused the most. Or you know, not following case plan because that is not the safest for them, or that they aren't able to check in weekly, or they don't have a phone. So sometimes not following through or risking their child's life or their life to make sure that they're safe during that. So there's many different ways that protective factors can be perceived or being able to be seen.
Thanks. And now we actually have a question from one of the audience members. So if you're working with a caregiver who does not think it's necessary for therapy for their child, one, is that a protective factor? And then two, is there a way that we can encourage them to at least look into it?
That's a really good question. It could be a protective factor. It could be there are plenty of people who are using abusive behaviors that use systems to continue to abuse a partner or place the child kind of in the middle of that. And so we've seen, you know, parents try to access records in order to gather more information and use that against a partner. We have seen, someone who's a caregiver who has used abusive behavior showing up at appointments that they know about because maybe there's a court order, or even in that order for protection, they still have access to the child, or to know about medical appointments or mental health appointments that the child is attending. And so sometimes there's like reasons that the parent is feeling hesitant. The identified safe caregiver is feeling hesitant to bring their child to therapy. So you kind of have to pull that apart with the parent sometimes, because it's not necessarily that they don't want their child to receive help, but are fearful about the caregiver who's using abusive behaviors knowledge or awareness of that appointment or ongoing service, and ways that may negatively influence the child and create more harm, which is confusing, I think, to experience as a provider when you're first trying to kind of pick apart what's happening. So the other piece is then, I would say, really making sure that you're referring families to services with providers who really understand domestic violence and can pick up on that, and can have conversations with caregivers about what their choices may be. It may be that getting therapy services at an agency or that is associated with the domestic violence shelter or at a child advocacy center may be a better choice than at a different outpatient facility that's closer to their home, where they might not be able to have that same understanding and conversations around what the caregiver's choices are when seeking services for that child, knowing that there may be complications and there may be conversations that they need to have depending upon what those court orders look like.
I think also acknowledging that this is maybe something that they are concerned about, and exploring that a little bit with them. As we know, some people who use abuse through the systems. And so there may be a history of there being consequences through various systems for this caregiver, and not wanting to, risk that again. But just starting with them, it seems like you're hesitant to do this. What are some of your concerns? And then just leaving the door open. Here are references. I'm happy to talk about this with you when you're ready. There's plenty of resources we can provide and support for you. And highlighting, we do this a lot with caregivers, is really highlighting the benefits of therapy for a child. And the person who asked the question is probably already doing this, but that can be important too. But really leaving that door open and not making it the support you're providing contingent on them doing that right now.
Awesome. So then when caregivers are sharing this information, what strategies are you using to support that?
So I think I guess I was just, segueing in, but we start where they're at. And so, and also honor their self-determination. We view them as the experts on their own situation. Remember, our clients have been trained in how to be alert to threat, even subtle threats that, people outside of that family system wouldn't notice. They've been trained on assessing those threats, and they've learned what behaviors keep them safe and what behaviors or protective factors don't keep them safe. So let's trust them as the experts on their situation. We always are saying, trust your gut, but we need to trust our client's gut. If our client's gut, if they're saying, this doesn't feel right, or this is how, this feels like this might happen, trust that. They're the experts on the dynamic that they're living in. And yeah.
Research has demonstrated that victims or survivors of domestic violence they are have the best judgment of what their lethality risk factors are. If they believe someone could harm them, then that increases the risk of lethality and safety for their children and for their family. And so that has to be our first step, is trusting the caregiver's report and exploring that further.
And remembering that, I don't know if we've mentioned this already, but it's been shown that the most lethal times for an abuse victim is when they're either getting a protective order or when they're trying to leave the relationship. And they're the best judge of that lethality, of that risk or that.
Yeah, I think another strategy that I use and that we try to practice is to be aware of your own biases. So when you're coming into a meeting with a caregiver or with a child, knowing the experiences you've had and how it's affected you. And so really paying attention to how you feel after meeting with that caregiver, and have some consultation around that, and being aware of, if you're feeling avoidant or confusion or upset of, meeting with that caregiver, using self-awareness as a guide to be able to figure out kind of what's going on, and to be able to have access to resources. So being able to depend on domestic violence shelters or services, reaching out to them, seeking consultation from them of, is this a red flag? What can I do to best support this victim who maybe doesn't see themselves as a victim, or if there's more cases coming up, being able to reach out to them and know the resources around you, like 211, domestic violence agencies, Day One, those sort of things. I think it's important.
Yeah, repetition of messages too, which it could be repetition of providing those resources or connections for support, repetition of information. We know that if they're in a heightened state of anxiety or numbing, they might not be able to access, all of those things from their memory or frontal lobe. If their, amygdala is going, if they're, highly anxious or hypervigilant at that time. So being patient and aware that you probably will have to repeat yourself and repeat the things that you're saying to them and giving to them, multiple times, and that's normal and that's okay. And I mean, with kids and with caregivers, and, everybody learns through repetition. You might need to do that more with with people who have experienced abuse.
I think something else is providing psychoeducation, and that might take time too, depending upon, where the caregiver is at in terms of their experiences or recognition of their experiences of abuse. Some families might come to you and really not know that they were experiencing abuse. This may have become a norm. It may be something that they experienced as a child, that there's intergenerational trauma that's been passed on. And so I think really recommending an individual or group therapy that's specific to where it's specialized for domestic violence victims and survivors. I think it's really important for caregivers to be receiving that support first or concurrently, but while their child is receiving support, because if you're still experiencing post-traumatic stress symptoms or ongoing active violence, you're not going to be able to better understand your child's lens as easily if you're not able to regulate yourself and get the support that you deserve and the safety that you deserve first and foremost. And so we do provide a lot of psychoeducation to parents, as well as helping them gain insight into their own experiences, how that's impacting their parenting in a non-shaming, non-judgmental way, as well as making sure that we're also providing them access to their own services concurrently with their children's. At Corner House, for instance, one of our children's groups for children who have experienced sexual abuse specifically, we have concurrent groups for caregivers at the same time so that we can teach the parents the same curriculum that their children are learning and the messages that we're giving children, so that they can repeat those to their children, so that they can understand them and ask questions and have space to connect with other caregivers as well and build community and safe community who are going to support them.
Thank you. So what are some examples of safety planning strategies that you use as your team?
We do safety planning a lot. I know Rachel can speak to a lot of the safety planning that she does immediately with with caregivers when they come in for the interview. We, you know, I'm always keeping in mind to, you know, be frank, be detailed, and be creative. So, you know, being direct about it, being concrete, like where can you hide a burner phone? Where is a safe place outside your home that you could run to if you needed to? Keeping, you know, a bug out bag of you and your kids, like a change of clothes and important documents if possible. Things that you might need, some money or something at a safe person's house. Identifying those social supports, people who you would be able to rely on or reach out to in an emergency. But also, like Rachel has mentioned, you know, accessing like shelters and safety resources and, you know, 911 if you're feeling like your life is threatened or if you're scared. You know, building confidence and trusting your gut to act on that to keep yourself safe. We do a lot of safety planning with kids as well. And so making a safety plan with them, depending on their age, we might do safety planning with stuffed toys that they can write on and keep in a safe place. With older kids, we might do a card, helping them identify where they would keep the card. And that kind of safety plan would involve, how do you know when there's going to be violence? Like, what cues are there? And is there anything you can do during that time that could help you be safe if violence occurs? And again, you know, identifying places you can go outside the home, inside the home for safety, people you can call if you need to, knowing how to call 911 and how to talk to the 911 operator. So just those are just some of the things, but doing that safety plan, which I think probably most of the people watching have done in some capacity or another.
Yeah, so this is kind of a two-part question that was also combined with one of the questions from our audience members. So first, how do you talk about safety if the caregiver is using the protective factor of staying with the partner who is having abusive behavior? And then also, how do you suggest approaching clients with the cultural or religious rhetoric that sometimes justifies domestic violence?
So I think to answer the first part of the question, validating and reflecting the reasons that they're choosing to stay, that reflecting back what you're hearing, or exploring with them those reasons, because we know there's a lot of compelling reasons that women stay, or that victims, survivors stay in abusive relationships, and that might be the safest for themselves or their children in the current circumstances. So trusting the caregiver's report around that and reflecting it back to them so that they understand, as well as can kind of integrate that and think about if there might be other options or choices, while still providing those other options or choices that might be better fit for them in the future, or might be safety planning might look completely different the next day. And one of those compelling reasons might be their culture, or might be the isolation that they would experience, that they couldn't maybe have a community member that would then take care of them or take them in if they needed support, is an example. And so I think it's exploring and listening and understanding and asking to understand more about what's keeping them in that relationship, and what is maybe there's been really good things about the relationship. We just don't know all of the possibilities. There's a ton of compelling reasons. We could do a whole presentation just on the compelling reasons for why someone may stay in a relationship that continues to be abusive.
Rachel, what about you?
Sorry, I wasn't unmuting. I think that it's important to always have continuing conversations and having open and non-judgmental questions for them. And I think the tone in your voice too, I think is really important, and your body language to be able to, I know it's hard over Zoom when you're speaking with clients, but continuously having those open-ended questions for them. Tell me more about that. You talked about this specific behavior. When does this happen? You know, can you tell me more about those examples or those sort of things, and allowing them a lot of choice, allowing them a lot that they are their own expert in their own life and their children's life. And I think that goes across, you know, any sort of race, cultural, those sort of things, and just allowing them to be able to speak about their experience and then dig a little bit deeper once you build that relationship and rapport with them. And I think it just, again, being very non-judgmental and being very open to other types of cultures and those sort of things too.
I think it's important to also, you may need to provide education about how this system works. If they're coming from a different culture where there's different norms for disciplining of children that they've learned and grown up with, they might not know what the rules are here. They might not know what the consequences of using those forms of discipline are. And so it might come down to educating them about our system. Look, if this is happening, this is the consequence. Like, the system will get involved, and you know, not to threaten them, but like, yes, I see you in the way that you're doing things, and I know, you know, listening to them about and validating that this is their family and their culture that they are coming from, and saying, in the system, technically, this is how this is going to be perceived by a system, and this would be the consequence then. It's not that, you know, you might have to be just give that education and be pretty direct about some of that, but coming from a place of like, I see you, I understand, and this is the system that, you know, is you're interacting with.
Thanks. So I know it's 1 o'clock, so some people may have to go, but there are a few questions, it looks like, from the audience. The first one being, at Corner House, do you refer parents of victims for therapeutic system or services? If so, about what percentage?
During an interview accompaniment, we are referring almost 100% of the time. Unless they're saying that they already have a specific therapist that they are seeing or being supported by. Oftentimes we're encouraging that, because even if the caregiver is saying that the abuse did not happen, or it wasn't a big deal, it was just touching, or it was just in another room, or it was just yelling, we say that either way that this child has been impacted, and that we encourage them to get therapy so that they can process this with someone who has it, you know, experience, and then also a professional who knows how to work with a child who has experienced either witnessing abuse or some sort of trauma or impact in their life. And I think that that is something that we navigate a lot, is that the caregiver might feel confused about the allegations, or might not know about the allegations. So I believe 100% of the time we give caregiver packets out that we're referring to therapists, unless they say we don't want anything. But that's our number one thing that we are supporting, because we know how important it is.
Thanks. And then, do any other children's advocacy centers have in-house therapy services that you know of?
Yeah, I mean, there are many child advocacy centers that have clinicians. Not as many, I would say, locally, but there are some. So if you send us an email, we'd happily send you, if you want specific referrals, we can absolutely provide those to you. And so Emma will make sure that the last slide is our contact information, and we can send referrals your way.
Yeah. It looks like we just have one more question. You talked about some behaviors children may exhibit as a result of exposure to domestic violence. What strategies do you use to help caregivers recognize that these behaviors might be related to domestic violence, particularly if a caregiver does not believe witnessing violence impacts their child?
That's a great question. I think I spoke to it a little bit before in terms of the psychoeducation that we provide, but we definitely, I think in terms of what Rachel was saying too, building strong and trusting relationships, building that rapport over time with caregivers who've experienced domestic violence is incredibly important. Sometimes when caregivers come in, they are not quite ready to have those conversations, or are feeling so overwhelmed by all of the systems that have suddenly become involved in their family's life, that it can be really hard to take in and process that information. And so I would say really slowly weaving in information, as well as taking time, if you're just meeting with the child, for instance, if that's your role, to separately meet with the caregiver to have time to explore what their experiences have been, to build that trust, and then begin to share your professional impressions about what the child may be experiencing, and remembering that you have expertise as a provider that oftentimes parents are looking for. They don't always come right out and say it, but they want to know how they can stop some of maybe the behaviors that their child is presenting with, or the reactions that their children are having as a result of the domestic violence. And so again, I'd be happy to provide resources that we specifically use with caregivers if you reach out to us, because we definitely have some handouts and films that we actually show parents sometimes, depending upon their experiences.
Thanks. So that looks like all the questions we have, and we are kind of on time. So this slide just gives you guys, our viewers, the contact information for our 3 panelists today. As Sarah mentioned, we invite you to ask any other questions to these email addresses specifically. You can also find a lot of information on our website as well. And with that, I'll hand it over to Ivy.
Thank you, everybody, for joining us. As I mentioned earlier, the link to the Child Abuse Summit is in our chat window, and I will also send a follow-up email with that link. So thanks, everybody. Have a really wonderful day.
Thank you.